Let's skip the basics and step right into a high-stress, trauma-based simulation. Today, we're zeroing in on rigid biochemical thresholds and the absolute high-stakes decisions you're going to face in endocrine emergencies. Look, when a patient's metabolic pathways collapse, your margin for error effectively drops to zero. So, in this explainer, we're going to map out the exact cognitive frameworks you need to conquer these clinical red lines, relying entirely on raw biochemical data to drive your choice architecture. Here's our agenda. First, we'll tackle DKA versus HHS. Second, the diagnostic forks of adrenal insufficiency. Third, the strict blockade sequence for thyroid emergencies. And finally, how to avoid those disruptive metabolic traps. Let's dive in. Section 1. Diabetic crises, DKA versus HHS and the potassium red line. Okay, we're dealing with two entirely different states of physiological crisis here. First, think about diabetic ketoacidosis, typically your type 1 diabetes patients. You're looking at an absolute insulin deficiency that essentially drives fatty acid degradation. And the result of that? A high anion gap metabolic acidosis, a pH dipping under 7.3, and heavy serum ketones. Now contrast that with the hyperosmolar hyperglycemic state, or HHS. This one is usually type 2, and it's defined by sheer osmotic diuresis. You're navigating extreme glucose levels, often blowing right past 600, and profound dehydration, pushing serum osmolarity over 320. But critically, this happens without the severe ketoacidosis. Now, regardless of which specific pathway you're looking at, your very first management step must always be volume repletion with isotonic normal saline. But here's the thing. Once you initiate fluids, you hit your first major clinical trap. Insulin is a highly potent effect. It drives potassium from the extracellular fluid straight into the intracellular compartment. Because of this, your insulin and fluid sequencing absolutely has to be based on the patient's baseline potassium level. If potassium is high, say over 5.3, you initiate insulin. If it's sitting in the normal range, between 3.3 and 5.3, you administer 20 to 30 milliequivalents of potassium concurrently with the insulin, just to stay ahead of the shift. But wait, what if it's low? If your patient's potassium is under 3.3 milliequivalents per liter, this is a hard stop. Seriously, do not pass go. Administering an insulin drip below this threshold precipitates catastrophic total body potassium depletion, which can rapidly lead to fatal cardiac arrhythmias or respiratory muscle paralysis. Let's actually test this framework out. Imagine you have a patient presenting with a glucose of 450, a pH of 7.1, indicating severe acidosis, and a potassium of 2.9. What is your immediate first-line intervention?
Well, if you reached for insulin to fix that glucose of 450, you just crossed a clinical red line. You must hold the insulin. Your correct, aggressive first line is IV saline and potassium repletion. Only once you pull that potassium back above 3.3 can you safely initiate the insulin drip to close the anion gap.
Section 2. Adrenal insufficiency diagnostic forks. Shifting gears to profound hypotensive shock, the crucial point here is distinguishing between primary and secondary adrenal insufficiency. Primary insufficiency, like Addison's disease, means the adrenal cortex itself is literally destroyed. Your labs will show low cortisol and low aldosterone. That loss of aldosterone drives hyperkalemia and hyponatremia. Plus, the pituitary goes into total overdrive, releasing massive amounts of ACTH and melanocyte-stimulating hormone, which causes very distinct skin hyperpigmentation. Secondary insufficiency, on the other hand, is a pituitary issue, most commonly from exogenous steroid suppression. Here, cortisol is low and ACTH is low. But notice the massive difference. The renin-angiotensin-aldosterone system, or RAS, remains totally intact, so you generally aren't going to see those severe electrolyte derangements or the hyperpigmentation. Now, when a patient's adrenal axis is failing, you have to execute hyperacute diagnostics. The gold standard here is the concentropin stimulation test. You administer synthetic ACTH and then measure serum cortisol at 30 and 60 minutes. If that peak cortisol level fails to rise above 18 micrograms per deciliter, you've confirmed adrenal insufficiency. But let's throw a wrench into this with a volatile scenario. You've got a hypotensive trauma patient who takes chronic prednisone, now presenting in vasopressor refractory shock. Do you wait around for your baseline ACTH or concentropin results before treating them? Absolutely not. An adrenal crisis is a full-blown medical emergency, characterized by circulatory collapse. You cannot delay life-saving steroids. You immediately push high-dose IV corticosteroids. Specifically, dexamethasone is the perfect blind intervention here. Why? Because it doesn't cross-react with serum cortisol assays. It allows you to stabilize their hemodynamics without ruining your diagnostic tests. A real lifesaver. Section 3. Thyroid storm blockade sequence. Enter the hypermetabolic extremes of the thyroid gland. These are essentially two sides of the same highly dangerous coin. Thyroid storm is your hyperthyroid decompensation profile. You're looking for hyperpyrexia, severe tachycardia, high output heart failure, and delirium. Myxedema coma is the exact opposite, your hypothyroid crisis profile, characterized by profound hypothermia, bradycardia, and hypoventilation. Both scenarios demand immediate ICU-level stabilization. Now, for a thyroid storm, you absolutely must lock in this strict, unyielding four-step pharmacological sequence. First, a beta blocker, like IV propranolol. This immediately blunts the dangerous autonomic activity and blocks the peripheral conversion of T4 to T3. Second, a thionamide, like PTU or methimazole, to block the synthesis of new hormone. Third, iodine therapy to block the release of preformed hormone. And fourth, hydrocortisone to further block peripheral conversion and treat any relative adrenal exhaustion. But pay close attention, because here is the absolute timing trap that you simply cannot miss. Look at steps 2 and 3. Iodine must wait at least 60 minutes after the thionamide load. So let's say your thyrotoxic patient is coding with a heart rate of 160 and soaring temperatures. You've already given propranolol. Do you push the iodine right away to stop that hormone release? No way! Giving iodine before the PTU has taken effect actually provides the thyroid gland with the raw substrate it needs to synthesize even more thyroid hormone. You will literally add fuel to the storm. You have to force that 1-hour delay to ensure the iodine blocks hormone release, utilizing what's known as the Wolff-Chaikoff effect, rather than fueling synthesis. Section 4. Clinical reconciliation and traps. Let's quickly, systematically catalog the easily missed parameters that precipitate coding in the trauma bay. Trap 1. Pushing insulin on a DKA patient with a potassium of 3.0. Remember, you must hold the insulin and replenish the potassium first. Trap 2. Administering iodine before propylthyrouracil in a thyroid storm. Always block synthesis before you block release. Trap 3. Giving fludrocortisone to a patient with secondary adrenal insufficiency. Their RAS pathway is entirely intact, so they only need glucocorticoids, not mineralocorticoids. And Trap 4. Delaying crisis-level steroids to wait for a cortisol panel. In refractory shock, you push dexamethasone immediately. All right, let's test your integration with a complex, boss-level presentation. You have a comatose patient rolling in with concurrent extreme hyperglycemia, profound hypothermia, and indeterminate neck scars. The raw biochemical data points to a dual crisis. Extreme glucose suggests HHS or DKA. The profound hypothermia strongly flags a myxedema coma. And those neck scars, they suggest previous thyroid or parathyroid surgery, heavily validating the hypothyroid risk. So, how do you sequence this? Well, you need thermal resuscitation for the hypothermia. But remember a crucial rule from our sources. If you administer IV levothyroxine for myxedema coma, you must give empirical corticosteroids first, because giving thyroid hormone all by itself can precipitate an Addisonian crisis if they have coexisting adrenal failure. And simultaneously, you're managing that hyperglycemic state with aggressive fluids, carefully checking the potassium threshold before you even think about touching the insulin. When these pathways collide, just knowing the baseline facts isn't enough. You have to master the precise sequencing to avoid making the crisis significantly worse. So, as you integrate these pathways, I'll leave you with this provocative thought. How will you systematically navigate this choice architecture when a clinical red line is crossed and a single, delayed, or premature medication stands right between recovery and total collapse?